Hi, everybody. My name is Nakul Raikar. I am a trauma and acute care surgeon from Brigham and Women's Hospital in Boston and assistant professor of surgery at Harvard Medical School. I have no relevant financial disclosures. I'm excited to cover abdominal trauma for this series. Management of trauma to the abdomen is complicated. It's a high density area for vascular structures and critical organs. Its management can rattle even the most seasoned trauma surgeons. In this talk, we will focus on a general approach to managing patients with abdominal injury, including an overview of the initial trauma resuscitation. We'll talk about specific areas, including use of ultrasound in trauma and damage control resuscitation strategies. We'll then transition to talking about the approach for trauma laparotomy and a specific focus on actual injuries to specific structures, such as the stomach, the duodenum, the pancreas, the spleen, the liver, the small bowel, the colon, the rectum, and the urinary tract. And finally, and perhaps most importantly, I usually like to say there are probably some people out there who can remember everything on command at any time. I am certainly not one of them. And after I got over my imposter syndrome, I have learned that most of us are actually not configured that way either. So it's important to know where to turn in those moments. And I will point to a few of my favorite resources that I use and that are available to any surgeon to help guide them in critical management decisions when you need it the most. All right, so getting started, the abdomen for trauma is defined as the area between the nipples and the pubic symphysis. This is because when you account for movement of the diaphragm, penetrating injury just below the nipple line can absolutely cause injury to an intra-abdominal structure. As such, the abdomen itself occupies a significant portion of the torso and houses a variety of complex organs and major blood vessels, all of which are prone to injury and require specific management strategies. The basics of trauma care remain the same as managing really any critically ill patient. The initial approach to a trauma patient with suspected abdominal injury includes a primary and secondary survey focused on diagnosing and treating threats to life and major morbidity from the standpoint of a patient's circulation, airway, and breathing systems. I'll point out that we often discuss the ABCs of trauma, and there has been a relatively recent shift away from that order to focus on circulation first. So now I remember it and teach it as the CABs of trauma. And the rationale for the shift is largely a reminder of the importance to resuscitate first, especially when you're proceeding to airway interventions. Any good anesthesiologist or critical care doctor will tell you the importance of a patient being well hydrated when you're preparing to induce and intervene on the airway. Induction typically precipitates some degree of cardiovascular collapse. And if that happens in the trauma environment and on a tenuous patient, otherwise, that just sort of pushes them into an even more tenuous state, or God forbid, they go into cardiac arrest. And now we might be treating that as a traumatic arrest and opening the chest and all the things that come with that. So, if possible, resuscitate first. Now, in most trauma centers or major hospitals, you'll have help and you can sort of attack these things simultaneously. But if you are managing a trauma patient in a center where you don't often do this, or you don't have a lot of help, certainly I think get IV access and get some blood or fluid running at the outset. Okay, so we're going to discuss three important aspects of the trauma bay evaluation, and that is sort of the variable approaches to patients with blunt and penetrating trauma mechanisms. the use of the fast, and then the concept of damage control resuscitation. So the first job of the trauma surgeon is to quickly classify the patient as hemodynamically stable or not. And victims of either penetrating or blunt injuries can have slightly different approaches and lead to different pathways. So I'll preface this with the reality that there's a lot of nuance to this, but for the sake of simplicity and clarity, we're going to generalize. In general, for patients with significant blunt force trauma, the goal is to proceed to a CT scan for a full assessment of injuries, given the likelihood of concomitant injury based off of whatever is obvious, or a lack of clarity on what those injuries are. Patients can sometimes come in with no major external signs of traumatic injury, and of course have significant injury on the inside. In general, patients with penetrating injuries need those injuries fixed in an operating room. Now, obviously, not all patients with penetrating injuries should be in an OR, and not all patients with a blunt injury belong in a CT scanner, or at least at the first stop. Penetrating injury is approached by the likelihood of intra-abdominal injury from a penetrating object. In either case, the point is that hemodynamic stability from an abdominal injury is typically going to be your ticket to the OR for exploration. So there is, I think, going back to the concept of nuance here. Again, in penetrating injury, patients who are stable may benefit from a CT scan, and this is becoming more and more common in our trauma centers as we see that there are some penetrating injuries that look like they are slam dunk cases for the OR, and then you scan and you see that the missile or the bullet sort of missed really the intraperitoneal structures entirely, or there is a liver laceration that could potentially be managed non-operatively. So a CT scan can be very instructive even in the penetrating trauma cohort. But I think the key principle is that if they're hemodynamically unstable and you suspect that this is an abdominal injury, then there are a few other places to go except for the operating room. So we'll transition now to talking about the FAST exam, which is focused assessment with sonography in trauma. It's become a staple in evaluation of the abdomen. It saves the patient and the treatment team valuable time as it can be done at the bedside, often while the primary or secondary survey is in progress. In brief, it has 4 views, 3 of the abdomen and 1 of the heart, and it's designed to help detect intra-abdominal or intrapericardial fluid. There is an extension of this called the extended FAST, and that includes views of the chest and largely looking for major hemothorax or traumatic pneumothorax, but we're not going to cover that since we're focusing primarily on the abdomen here. So a wide range of studies over the past several decades have demonstrated that the sensitivity for detecting blood in the abdomen ranges from 30 to high 90s in terms of percentages. But this is often dependent on the clinician performing the exam, the interpretation of the images, the body habitus of the patient, and the clinical status of the patient, because we all know in a patient that is moving or difficult to examine in general, it can be difficult to get good images. But with favorable factors, the sensitivity is really excellent for a FAST, and some more recent studies put the sensitivity at somewhere in the 80% range. And it has fairly high specificity across many studies. So if you see blood on the ultrasound you can be pretty confident that there's intra-abdominal or intraperitoneal free fluid and blood. Now, whether there are circumstances that you're going to miss the blood because of the sensitivity being a little bit lower is certainly a consideration that you have to be worried about. Now, putting a patient in Trendelenburg position, for example, can help increase the sensitivity, as it can help the blood collect or pool in areas that make it a little bit more obvious on the FAST exam. So it kind of leads to the adage that if the fast is positive, you better act fast. In fact, there was a study done almost a decade ago now that showed the hazard ratio increasing by 1.5 for every 10 minutes. There was an increase in time to operating room after a positive fast. And one reason for this might be that you probably need somewhere between 400 and 600 cc's of blood in the intraperitoneal space to be able to pick that up with ultrasound on the FAST exam, versus something that you can pick up obviously much smaller volumes of blood on the CT scan. And so if someone has half a liter of blood in their intraperitoneal cavity, they're probably bleeding a decent amount. And so you should certainly allow that to guide you and your team to the operating room in a expeditious manner. Another new concept that we need to sort of talk about, not particularly new, but important concept that we need to talk about, is the idea of damage control resuscitation. And we will cover the specifics of resuscitation strategies. But central to this concept is the long known lethal triad or trauma triad of death. And essentially, what this addresses is that temperature dysregulation is a major problem. Patients lose blood. We often replace that lost blood between the pre-hospital space and the initial trauma resuscitation with IV fluids or blood. Typically, these are cold and not warm fluids. This hypothermia severely affects the coagulation cascade, and that can itself lead to coagulopathy. And then the coagulopathy leads to more bleeding and decreased oxygen delivery to tissue, leading to increased lactic acidosis, which leads to decreased cardiac function, which again leads to hypothermia. And so this has more recently been expanded to what's being called the trauma diamond of death, which really just introduces and highlights the outsized role that hypocalcemia plays in this process. Calcium is an important cofactor in a lot of the enzymatic processes that govern the coagulation cascade, and it's also super important for platelet function. And so why do we worry about hypocalcemia specifically? Well, a couple of reasons. One is because it's often exacerbated by iatrogenic causes, specifically blood transfusion. Citrate is used to prevent blood from clotting in the blood bag, and each bag contains probably about 3 grams of citrate. And the liver can only process a certain amount of citrate, and so with massive transfusion or high volumes of transfusion, that citrate can stick around in the blood for a while. Citrate is a calcium chelator, and with, again, decreased calcium, we just talked about the trauma diamond of death. Decreased calcium inefficiency in the coagulation cascade can, of course, lead to cardiac dysfunction, and then hypothermia and all the other things that we talked about. So what can we do about this? Well, one option is to be very mindful about administering calcium. And so some military protocols and protocols in civilian centers are changing quite rapidly. But you can administer a gram of calcium right off the bat with your initial resuscitation, and then as they get additional units of blood, whether that's 4 or 6 or some predetermined amount, you can give additional um, amounts of calcium, and you can also do it based off of the ionized calcium level and resuscitate in a goal-directed way at that point once you have the information that can help you. So that information has all been around for a while, and the science behind resuscitation has been around for a while. However, I'd say that the science specifically related to hemorrhagic shock has been rapidly evolving over the course of the past 10 years. As recently as 10 years ago, the common guidelines recommended 2 liters of crystalloid resuscitation in hypotensive trauma patients, followed by packed red blood cell administration. And we now recognize that when patients have lost blood, it's best to replace this volume with blood, preferably whole blood or your institution's best approximation of it. Study after study has shown that resuscitation strategies, which include a high ratio of plasma and platelets to RBCs, i.e., approximating the constitution of whole blood, have shown improved outcomes in trauma mortality. The 2017 East trauma guidelines recommend equal amounts of RBC, plasma, and platelets during the early stage of resuscitation in severely injured bleeding trauma patients. Note that in most institutions, platelets are still pooled together in packs of 4 to 6. So actually, in practice, this often translates to you give a patient 6 units of red blood cells, you give them 6 units of FFP, and then give them a unit of platelets. And so every time you hit the next iteration of 6 red blood cells and plasma, you should be giving them additional platelets. Now, the whole blood or the use of whole blood is gaining recognition around the world for its efficacy in treating severe hemorrhagic shock. It's been shown to be superior to red blood cell transfusion alone. Whole blood, of course, was the original resuscitative fluid when blood transfusion was invented. And conceptually and physiologically, if you're losing whole blood from bleeding, replacing it with whole blood, which also contains all of the coagulation factors that are found in plasma as well as platelets, makes a lot of sense. Now, most blood banks in the United States do not stock whole blood. There are probably a lot of reasons for that. And there are very good reasons for why they stock components with RBCs and FFP and platelets. In many ways, it's more efficient. Most hospitals are not major trauma centers, and so the blood banks do cater to a wide range of needs. And there is also heterogeneity in what is considered whole blood. A lot of the military studies were based off of fresh whole blood. A lot of the civilian studies use some version of cold stored whole blood, O positive, O negative, leukoreduced, not leukoreduced. So, while whole blood is probably better, if your center does not offer it, it's not the end of the world. The clinical difference between a 1-to-1-to-1 resuscitation strategy versus whole blood is probably not that different. And some of the more recent, meta-analyses have come to that conclusion, or at least we're not able to detect a big signal. So carry on, and we'll hopefully this becomes something that is offered more widely. But But in the meantime, I think we get pretty good outcomes by sticking to a 1-to-1 resuscitation strategy. It takes a little bit more effort on our part in terms of remembering and keeping track of the resuscitation, but it's just another part of the job. So let's chat about what happens once we get to the operating room. And so I think prepping for a trauma laparotomy is a skill that I always talk through with the residents, even if we're not doing a trauma laparotomy. You've got to really minimize wasted time in the operating room. And so having the team ready to go and knowing exactly what to do is really important. So typically prep widely from the neck all the way down to the knees. And if an extremity is involved, you need to access, then also prep in that extremity. Um, so, blue towel should go all the way down and then cover the genitalia with another blue towel, and then you can either use it as such or use IBAN or whatever your preferred sort of mode of keeping this nice and neat. But certainly many different options. Once you are ready to go, keep moving. So, one of the things that has been famously described in the classic trauma book, Top Knife, which highly recommend, is the idea of sort of swift, definitive entry into the abdomen when we're dealing with a patient who is bleeding extensively into the abdomen. It's described as 3 strokes, once through the skin, the second stroke kind of going through the subcutaneous tissue right up until the fascia, and the third going through the fascia and then into the peritoneum. The next step is to pack all 4 quadrants of the abdomen rapidly, with or without sort of deliberate evisceration of the bowel. In my practice, I find early evisceration of the bowel allows you to more effectively pack the rest of the abdominal cavity. It also allows you to identify mesenteric bleeding from other injuries deeper in the abdomen. And remember, packing is a swift, rapid, expeditious process, but it should be purposeful. I usually ask for a stack of packs from the scrub tech in the room, and we have at least 5 for each quadrant, and sometimes more, and put them in quickly to stop the bleeding. Remember, the trauma lethal triad or the trauma diamond of death that we just covered. It's really important to remember in the operating room because acidosis, coagulopathy, hypothermia are really brought on by severe hemorrhagic shock and prolonged operations. The longer the patient stays in the operating room with an open abdomen exposed, the colder they get, the more acidotic they get, the coagulopathy gets worse. And so try to get out of the operating room as quickly as you can, having done what you need to do at a bare minimum. And that brings us to the concept of damage control laparotomy. So the goals of the index operation then in a severely injured trauma patient are really twofold: to control the bleeding and to control contamination. This reflects an evolving view of the role of surgical intervention in trauma. The paradigm has really turned towards shorter trauma operations, preferably less than 90 minutes long, focused on hemorrhage and contamination control, and a staged approach to surgical correction of anatomic defects at a later time. So, for example, a damage control operation might include packing the liver, shunting of a blood vessel, or if necessary, direct ligation of a bleeding blood vessel instead of a extensive sort of reconstructive operation. Instead of being in the operating room for hours to fix all of these injuries and address all the problems. So the focus is then to resuscitate patients, warm them, correct the metabolic coagulation profiles in the ICU setting with or without adjunctive procedures like angioembolization with our colleagues in interventional radiology. And then once they are physiologically showing some sign of recovery or stability, we return back to the operating room 24 hours later, 48 hours later, for a more definitive repair of injuries. The abdomen can be closed in the interim with a number of temporary abdominal closure techniques that are long described. Common option we currently use at our center is the Abderavac system, but there are many ways of doing that. Now we're gonna get into the moving on to the liver. The liver is one of the most commonly injured organs in the abdomen. The liver is highly vascularized, and even low-grade injuries can bleed dramatically. The portal vein supplies the majority of blood flow to the liver and approximately half of its oxygenation. The remainder of its oxygenation is typically attributed to the hepatic artery. These are not, however, the only two sources of bleeding. The liver is intricately associated with the inferior vena cava, and there are three large hepatic veins and their branches that drain the liver directly into the IVC. So bleeding from the hepatic veins can often be, the most difficult to control. It's important to keep note of the liver's attachments. The liver is attached to the diaphragm with coronary ligaments, and the lateral extensions of these to the right and to the left are known as triangular ligaments. Adequate mobilization of the liver to control bleeding usually requires taking down these attachments, because without that, it becomes sort of difficult to tent the liver or to compress it in the specific orientation that it requires to obtain hemostasis. This is the Western Trauma Association's non-operative algorithm. Hemodynamically normal patients with liver injuries identified on CT scan can be managed non-operatively, and included in this pathway, as you will see, is the option for angioembolization. But we're going to focus on the pearls of operative management that really any surgeon who operates in trauma scenarios should be aware of or be ready to pull out in cases of sort of persistent liver bleeding. So the first objective of treating the liver is to pack the liver. This will dry the field and potentially slow down or stop bleeding while you plan your next move. Much is said about packing the liver, quote, appropriately and quote, inappropriately. But the key principles to keep in mind are to reapproximate the size and shape of the liver. Don't pack into the liver crevice, pack externally to put the liver back into its normal configuration. And while packing inferiorly and posteriorly, beware of packing off the inferior vena cava. This can be catastrophic, cutting off venous return to the heart. And so I think if you follow those two general principles, or at least keep those things in your mind, it will be, you're going to be fine. As we said, the ability to pack can really be hindered by the liver's attachments to the abdominal wall and diaphragm. And so you may need to mobilize the liver in order to get some packs in there that actually help reapproximate the liver as opposed to not. With persistent bleeding, the next move is often to perform a Pringle maneuver. This is essentially compression of the portal triad, and particularly the portal venous and hepatic arterial inflow into the liver. You can create an opening in the gastrohepatic ligament and then either clamp or pinch, close the portal vein, artery, and also common duct. The liver tolerates intermittent clamping of the portal triad. um, quite well as opposed to continuous ischemia. So, many centers follow protocols, especially liver transplant um, facilities, to release the Pringle every 10 to 15 minutes for a period of time, often 5 minutes, to allow for perfusion when you have to Pringle for an extended period of time. Now, if the Pringle slows bleeding, you're in decent shape. You can decide if this is a simple or complex liver laceration. A lot of low-grade injuries can be managed with a combination of electrocautery and thermal energy devices, the argon beam, the Aquamantis, large blunt-tipped sutures, hemostatic agents like Surgicel and VistaSeal, for example, can be quite useful. In cases of severe hemorrhage, I'll often call for all of these agents and whatever is available at the institution to use them sequentially. If the Pringle does not slow down bleeding, that is a little bit more concerning. So this is when you should probably call for help. If it's coming from the laceration, the same techniques mentioned above can be used to try to control it. If the liver is badly damaged from a complex laceration, the bleeding is profuse, you might need to do a partial hepatectomy. Typically in these scenarios, you can fire the stapler across the liver parenchyma and resect the damaged lobe. When I have done this, this is usually in the setting where the liver is already partially transected on one of its ends, and so coming across and sort of completing that hepatectomy allows you to then focus on the remaining segment of the liver's remaining segments of the liver, and you can address it accordingly. Now, if the bleeding, though, is coming from around the liver, behind the liver, this is concerning for a retrohepatic injury to the cava or the hepatic veins that are flowing into the IVC. This is often a catastrophic injury, very high mortality, total hepatic venous isolation is described, as the next move, essentially saying that you're going to obtain proximal and distal control on the IVC. Infrahepatic IVC control requires at least a partial right to left medial visceral rotation and mobilization of the right colon, with or without a Coker maneuver to mobilize the duodenum off the IVC. Suprahepatic IVC control can be achieved a few different ways. Sometimes control of the IVC, though, is best obtained above the diaphragm. If you're already in the chest for another reason, that can be a very effective way of doing it: a right thoracotomy, median sternotomy, or getting directly into the pericardium, either, again, through the chest or by incising through the diaphragm, and then getting to the IVC that is within the pericardium can often also work quite well. Now, historically, folks have described things such as the Schrock shunt, essentially shunting the IVC through the right atrium with a chest tube. But this is largely historical significance. In some centers, veno-venous bypass is an option, but again, really, there are lots of challenges in mobilizing that in most places. So worth thinking about before this happens. But if you work at a center where that's a possibility, you probably already know it. Moving on to this